Okay, well, good morning or afternoon, everyone. As we would like to sort of introduce the trauma systems consultation that we'll be doing next week for the state of Georgia. My name is Brian Eastridge. I will be the team leader for the meeting. First of all, I'd like to thank the state of Georgia and the Georgia Trauma Commission for the opportunity to do this review. We're very excited to be coming back to Georgia since the last consultation in 2009. And we hope that we can offer some recommendations for iterative successes from the successes you made since subsequent to the 2009 visit. The first thing I want to do is I want to start off by having the team introduce themselves. So I'll start off. So I'm Brian Eastridge. I'm the Division Chief for Trauma and Emergency General Surgery at UT Health in San Antonio, and I am the Trauma Systems Pillar Chair for the ACS COT. And Dr. Staudenmeier.
Hi there, nice to meet you all. Kristen Staudenmeier, Associate Professor of Surgery at Stanford, and I am currently the Vice Chair of the Trauma Systems Pillar.
And Dr. Oli.
Good morning. My name is Billy Oli. I'm on the Rural Advisory Council to the Committee on Trauma for the ACS, and I practice emergency medicine in South Central Montana and Southern South Central Alaska for the past 20 years.
Great. Dr. Pearson.
Hello, I'm Mike Pearson. I'm the chair of acute care trauma surgery at a level 2 center in South Dakota, and I'm the rural chair for the COT.
Great, thanks, Mike. Dr. Kirby.
Hey everyone, Jeff Kirby. I am the director of the Division of Trauma and Acute Care Surgery at the University of Alabama at Birmingham, and the current chair of the Committee on Trauma.
And we have two other professional members who, Dr. Sandy, who I don't believe can join us today, and Ms. Klein, were you able to join us? So Jory Klein, many of you know Jory Klein. Jory Klein works for the state of Texas, running trauma programs for the state of Texas. Ms. Neal.
Hi, Melanie Neal, Assistant Director for Trauma Quality Programs at the college.
Great. Ms. Michaels.
Hi, Holly Michaels, Manager of the Trauma Systems and Injury Prevention Programs at the college.
And last but not least, Ms. Daffner.
Hello, Mackenzie Daffner. I'm the Program Manager for Trauma Systems Programs at the college.
Great. So we have assembled really a great team with many years of experience doing these trauma systems consultations, and actually have got some special representation from rural surgeons and rural emergency medicine providers to help provide you with this consultation. So I'm just going to give you a brief overview of what the consultation process is all about. And then what you can expect next week, sort of looking at sort of logistics. So looking at, trauma systems across the United States, sort of shown there in purple, are relatively representative of the population. Many of the trauma systems are in areas that are sort of population centric, but much of the landmass of the United States is actually not covered by trauma systems. So rural healthcare, rural trauma care is a significant issue across the United States. And obviously you can see there in parts of Georgia, sort of southern Georgia and northeastern Georgia, that rural trauma care is a significant issue. If you look at what that means in terms of outcomes, this is basically a vital statistics study done from 2015 to 2020. Those areas that are better represented by trauma centers and trauma care have far less age-adjusted mortality for injury. So overall, the urban and suburban areas of our country are actually fairly well served by trauma centers. Though this geographic distribution of trauma centers is not really well coordinated or planned or population centric, it's just largely it's driven politically and by health center interest in having trauma centers. Excess capacity is actually excess capacity is relatively uncommon. Incentives for trauma center care are variable around the states. Again, the state of Georgia has actually done a great job since that 2009 visit with developing incentives for trauma center creation and actually seeing iterative growth of their trauma system. Again, rural and frontier areas of the states are largely are challenged because of geographic area, limited resources, and with that limited resources, obviously limited funding to develop trauma centers. Trauma centers and trauma systems are costly entities to maintain. So again, it's difficult to maintain these in a rural area, and obviously they're hindered by long transport times, which has been associated with worse outcomes after injury. Some of the challenges that we see in trauma systems, that no two trauma systems are exactly the same. They're driven by public awareness and regional policy. Now, that can be a good thing or a bad thing. If you actually have the wherewithal to have strong advocacy and public awareness, that can actually be a significant advantage to development of trauma systems. But most trauma systems and most regions don't have the sophistication to develop that advocacy and public awareness. So it's really an untapped resource. The authority and the empowerment of the lead agency is variable, often driven by demands from usually the state. There's challenges with system-based planning and operations, again, for resource allocation, quality assurance and financing, and there are competing priorities. Some of the ones that are obviously most prominent are the designation of trauma centers, or the designation of trauma centers by need rather than healthcare system desire, and also that is associated with the control of patient flow in those trauma systems. So the trauma system is complex. It's inherently political. Again, from all the work that's been done since 2009 in Georgia, I'm sure that y'all are very aware that the process is very political, and to gain any inroads and advancement, you need to have basically that you need to have advocacy, you need to have strong champions, you need to have strong leadership to develop your system. There are large differences in scale and trauma systems across our country. The smallest trauma systems, are regional trauma systems that are exist in municipalities or county or collections of counties across the states. And the biggest trauma system we have in our country is the state of Alaska. And you can see that the state of Alaska just as a single trauma system from north to south spans almost the entire north to south borders of the United States. So again, inherently, there's going to be differences in scope and scale when you're talking about trauma systems of that magnitude. Injury care is really not an instinctive priority. We have not done a great job in the injury community of being able to foster injury care as a public health threat. So if you look at just the number of deaths per year associated with injury, and you take HIV, tuberculosis, malaria, this is from data from World Health Organization, the most other diseases really pale in comparison to the mortality associated with injury. There's no right answer. Again, every time we do a consultation, we realize that, again, every trauma system is unique. We use a set of global concepts doing our consultation processes. And when we render those recommendations, we realize that the solutions are really going to be driven by the stakeholders at the local level. So when we do these consultations, we try to give salient recommendations that are, again, going to be realistic and relevant to the communities that we're doing those consultations in. But the solutions will be driven by you, the stakeholders. It's a huge undertaking. For those of you that have participated in the early development of the Georgia trauma system, I'm sure that's evident to you. It takes a long time. So even though that we've had, Georgia has had really tremendous success and is really a shining star with respect to trauma system development across the United States, it has taken a long time to make advances in the Georgia trauma system, and there's still work to be done. Hence the ask for this second consultation. Process can frequently, stagnate. You have turnover in leadership, loss of the shared vision, and certainly there's the potential to have progress lost over time. So periodically, you really need to rekindle the spirit to develop your trauma system. And I'm hoping that this consultation that we're going to do next week will be one source of rekindling that spirit and that energy to advance Georgia forward for the next decade. We look at these consultations from the perspective of development of inclusive trauma systems. So really using all of your healthcare entities across your system so that minor injuries can be treated at virtually every hospital. And then you have a tiered incremental response to healthcare and injury care, where more severe injuries, higher acuity injuries, are going to higher level trauma centers. So our consultation process, we have been at this for about 2 decades, started in the late 90s. The Trauma Systems Evaluation and Planning Committee was established in the early 90s, so I guess now it's 32 years. With 6 past chair, we've done over 45 consultations. The program was initially modeled after the Trauma Center Verification Program, but very early on it was seen that that was going to be problematic, again, because of the heterogeneity of trauma systems, that there really wasn't going to be a way to do a formal standards and verification process. So we shifted the focus in the late 90s to doing consultations, and have done consultations again from very small municipal systems up to obviously large state systems. The mission of the trauma systems pillar of the American College of Surgeons Committee on Trauma is really, we want to develop and lead programs, of which the Trauma Systems Consultation Program is one, initiatives and collaborative efforts so that we optimize regional and state trauma systems and establish a framework for a national trauma system to reduce preventable deaths and disability. So the systems pillar is doing a lot of work in addition to the consultations to drive system development at a national level. Some of the current initiatives we're working on for the trauma systems perspective is consultative visits. Again, most of our visits are state-based, but we have done several visits at regional levels, and actually have done some problem-focused analyses for the consultative process. We're also working at the national level on policy development to enhance and develop and sustain trauma systems across the United States. We're looking at areas to potentially develop trauma benchmarking. And, one of the things that we're also looking at is how that we can potentially develop tools to help systems substantiate trauma center placement based on need. And one of those initiatives is based on geospatial indices. And lastly, we're working on current initiative is the National Trauma and Emergency Preparedness System. We're working on this with several partners across the professional continuum, including ACEP, NSEMSO, NAEMSP, and many other partner organizations to drive awareness or help serve to project awareness and of injury as a public health threat across the nation, and drive a national initiative for the development of a national trauma and emergency preparedness system. So this is where we started back in the late 90s with our first trauma system review in the state of Montana. And again, we have some colleagues from the state of Montana with us for this review. Montana is interestingly largely rural. And over the course of the last several years, we have again continued to advance across the United States. And we did our Georgia consultation in 2009 again. So current year to date, we have done about just shy of 50 consultations for the consultation program. So with respect to sort of, what the consultation is, it's a consultation. We will yield recommendations from this consultation. There are no true standards or benchmarks at this point. And we're really looking to have open and honest discussions, candid discussions about your trauma system so that we can help facilitate collaborative solutions that are really, again, going to be salient to the Georgia trauma system, particularly some of the rural trauma system needs in the state of Georgia. The multidisciplinary team is tailored to meet the needs of the consultation process. We always have a lead surgeon and a second surgeon, an ED physician, a state EMS director, and a trauma program manager, as well as our ACS staff team, who are very valuable to this process. But again, because of the special request to do a deeper dive on the rural components of the state of Georgia, we've added some additional expertise with some rural surgeons and a rural EM physician to help get into some of those, to look at some of those needs that the state of Georgia wants to investigate. For the consultation, it's a 4 to 5 day visit. This is, since we're going to be doing some traveling, it's going to be, there's some, again, more intensive review on the rural component of the Georgia system. We're going to we'll have a 5-day visit next week. We've already collected some data through the pre-review questionnaire. We'll review, there'll be other data that we'll ask for and review along the way. The most important thing that we do in this consultation, particularly when the on-site consultation, is we want to hear from stakeholders. We want to hear from the challenges that stakeholders have. We want to hear the successes. We want to hear ideas for advancement of the Georgia trauma system. That's one of the most important parts of this consultative process, is the interaction with stakeholders. So we're going to make a very intensive effort to get around the state next week. We'll be in three sites around the state in doing this consultation. The recommendations that come out of the consultation will be derived by team consensus. So that will be done at the latter part of the week. And again, all of this will be based on the concept of the global concept of an inclusive public health model and an inclusive trauma system. So our priority is not about healthcare systems. It's not about the ACS. Our priority in doing this consultation is really what's going to be best for your injured patients in the state of Georgia. So the process next week, our group will fly in on Sunday. we'll have some pre-review meetings on Sunday afternoon and evening. On Monday, we'll have state stakeholder regions centrally at the state level. Basically, it's a question and answer discussion. Day 2 on Tuesday, we will go to Southern Georgia to have a focused stakeholder meeting, really focused on some of the rural challenges and rural needs for Georgia. On Wednesday, we will drive to Northern Georgia and basically do the same thing. And then the last couple of days, we have internal meetings, team deliberations, start drafting the report, and we'll have a virtual exit presentation with sort of the higher level findings and most significant recommendations that we'll deliver verbally. So generally, that virtual exit presentation, we will go through sort of our higher level findings. We generally settle on about a dozen high level recommendations and opportunities that can be really acted upon because they, again, should be acted upon because they are more, as we see as consultants, sort of the higher acuity challenges in the system. But when we actually finally get the report back to you, that you'll get the comprehensive list of recommendations, and often that comprehensive list will have anywhere from 75 to 100 recommendations in the final consultation report. About 8 weeks after the site visit, through further team deliberations, we'll continue to refine the report and refine the report writing. After 8 weeks, we'll do a preliminary report. Will go to the state basically for fact checking, making sure that there's no overt errors or anything that needs to be corrected. And after a couple of weeks of going back and forth with the state, we'll produce the final report to the state about 10 weeks after our initial consultation. Again, we want to say that these are broad general principles. We're going to look at the Georgia system from the perspective of an inclusive trauma system. We realize that the solutions are going to be yours, and all the solutions really have to be derived and driven locally. So the system development steps really require some flexibility. So there has to be, allow for, some flexibility so that you can develop solutions at the local level, and even particularly in your situation at the rural level. So we've already introduced ourselves. This is the team that will be visiting next week. Again, so in closing, I want to say that, again, we are honored and appreciate the invitation to review the state of Georgia trauma system next week, and we are looking forward to our visit. Ms. Atkins, are you there?
Yes,
Thank
sir.
you, Dr.
Just waiting.
Go ahead, Liz.
Oh, that's okay, Holly. Thank you.
I was just
Dr.
turn it over to your presentation.
Liz, can you hear me?
Yes, sir.
We can hear you.
Okay. Hi, Brian. Thank you.
Hey, Dennis, how are you?
Okay, great presentation. Can you see my slides okay?
We can
Yep.
see him, yes.
Okay. All right. Well, thanks, Brian. That was a great introduction, and we're very excited to have you and your team here in the state. It's very impressive as you went through the list of names and of the team that you've assembled. So It's a very impressive team, and we're very thankful that so many talented people could take time out of their busy schedule and spend a week in Georgia. I know that's no small task to spend a whole week away from home. So with that being said, I'll go ahead and get started. I think we have over 100 people on the call. So some of you have seen this presentation that I gave at the COT, that the COT was kind enough to request an update from the Georgia system. And so a lot of people didn't get to hear that presentation. So we're going to hit the highlights today. Obviously, I can't cover 10 years in just a few minutes, but we'll sort of hit the highlights. And then I'm sure during your site visit, the other areas of accomplishments will come out. So as Pat O'Neill used to say when he would talk from the Office of OEMS&T and Department of Public Health, the trauma system has been many years in the making. We're now up to 41 years, but who's counting? Georgia's first trauma center was designated about 42 years ago in Rome, Georgia. And since that time, we've come a long way, as you can see from our first ACS visit in 2009. Tremendous work has been done. Around 2006, we were having significant problems. Trauma centers were threatening to drop out of the system. CEOs got together of various trauma centers and went to the governor and the legislature and said, something has to be done. We're underfunded. We don't have a system. And the legislature really wasn't quite sure what to do with all that information. So they created a legislative study committee that was made up of 5 members of the House and 5 members from the Senate. They heard testimony from state and national trauma experts and held 5 regional public meetings. And this was their key findings. There were a lot of findings, but as Brian said, they drilled those down to a few key findings. Georgia's trauma death rate was 20% worse than the national average. Only 30% of severely trauma injured patients were treated at designated trauma centers. And the trauma death rates in rural Georgia are much higher than in urban areas, as you would expect. And annually, Georgia's trauma care providers, made up of hospital surgeons and EMS, delivered $250 million in uncompensated trauma care. So it was obvious that this could not continue. And through that review, we realized that we were going to have retention problems, as this trauma centers were already threatening at the board level. Some of this had risen to the level of the boards of the trauma centers to get out of the system. We also noticed some areas here on the map. You can see the counties outlined in red down that corridor along 75. And if you look at the colored circles, you see in sort of light yellow, that's about 25-mile circle. The lighter teal colored is about 50 miles. And you can see, as already been stated, down in sort of that southern part of Georgia, there's a lot of areas, and 75 goes right through those areas. So this was sort of people started calling this the corridor of death, because as we started looking at death rates in these areas, they were much higher because they were farther away from trauma centers. And obviously the speed was much higher coming down or going up 75. So Dr. O'Neill, after that visit, coined the phrase "islands of excellence in a sea of chaos." And I think this has sort of been one of our mantras throughout the years. It's really describes our system. It did then. Things have improved, but we still have areas that we need to improve on. So the 2009 ACS consultative visit came up with a lot of recommendations. I think there was over 100 recommendations. There were 12 priority recommendations, and you see those listed here. I won't go through every one, but I will highlight just a few for the rest of the talk. We'll talk a little bit about trauma system plan, trauma system integration, financing, system evaluation and quality assurance. And we'll get through all those in the next few minutes. So as far as trauma system plan, we needed to develop a comprehensive trauma system plan through a collaborative process. We really didn't have a plan in the state of Georgia. There was a lot of suggestions here and there, but there was no cohesive plan. We needed this plan to guide development of enabling legislation as well as resource allocation. Also to identify roles for all hospitals and stakeholders in an inclusive trauma system within the trauma system plan. This was a collaborative effort between the Georgia Department of Public Health, the Trauma Commission, the Governor's Office, Planning and Budget, trauma centers, trauma care providers, and pre-hospital personnel. The mission was to implement a statewide patient-focused trauma system that provides optimal pre-hospital, hospital, and rehabilitative care to trauma patients while creating strategies to reduce injury rates. And the vision was a safe and secure environment for all Georgians, enhanced by a functional, integrated, and continuously improving trauma system. And you can see the front cover of the plan here that it was made up of 7 components or categories, and you can see those listed here. I won't go through each one, but certainly legislation and finance has been a key, and I think we've been pretty successful in that arena. This was not finalized until 2015. You can see 6 years after the 2009 consultative visit. So as Brian said, things don't always move quickly. You have to look at these things with working with the state system as a marathon and not a sprint. So it took us a while to get there, but eventually we did. 2020, the plan was to undergo a revision or review, but obviously with the pandemic, that has slowed things down. It's a beautiful plan on paper. It's well written. I think it covers all the key topics, but we still lack funding to operationalize all components. Even with our $23 million budget a year, it seems like a lot. It's woefully underfunded. Okay, moving on to system integration. This was to establish multidisciplinary RTACs centered or regional trauma advisory committees centered around a level 1 or level 2 trauma centers, include representatives from trauma centers, acute care facilities, and EMS services, ensure oversight for the lead agency, and build upon existing EMS regional councils as appropriate, recognizing that there may be incongruency and overlap with regional boundaries. So what do I mean by that? Well, you can see Georgia is divided up into 10 EMS regions, and you can see the map to your right, the location of the trauma centers, and they don't always line up. Some regions have several trauma centers. The one region in Georgia until recently didn't have any. And so, but this was the best regional mix that we had. We already had EMS councils in place. There was great discussion about forming RTACs totally independently on their own, but they didn't really have any infrastructure. So we've embedded those in the EMS councils to give them a home and then work to develop regional coordinators. So our RTAC activity lacked continuity across EMS regions, as I said. In 2009, we started building our regionalization through pilot projects. Region 5 in the middle of the state and Region 6 were the two sort of pilot regions to learn how to build the RTACs. We had some hard knocks and missteps along the way, but through these pilot projects, we learned to where I think our RTACs are really developed into a nice process at this time. This has been facilitated by pre-existing infrastructure in the EMS councils that makes a nice connection between OEMS&T, DPH, and the Trauma Commission. By 2021, all 10 EMS regions were active. We then started to look at grants and funding because these RTACs really didn't have any funding at all. And this was provided through the commission. And you can see there we developed regional improvement grants that the RTACs could apply for and then make projects local. What worked in one region or what was the need in one region might not be a need in another region. Each region was also required to submit a BIS assessment and a regional trauma plan that was to be tied into the state trauma plan so that we would all be aligned. Moving on to system or continuing system integration, one of our first projects was the Stop the Bleed campaign, which was $1 million provided out of the Trauma Commission budget for bleeding control kits in all Georgia public schools and eventually on buses. The RTACs were the backbone of the Georgia Stop the Bleed school program. The commission provided the funding for the kits. That was the easy part. I mean, somewhat easy, but it was $1 million. But again, the hard part was really training every teacher or training a cadre of teachers, school experts, if you will, in each school across the state, and then putting those kits in the schools, 10 to 12 kits in every school. So this was all done by volunteerism through EMS, through trauma program managers, through nurses. This was really a heavy lift. And I just can't thank across the state the people that participated in that enough. This was all blood, sweat, and tears. No money was spent on training. This was all done through volunteerism. So it was a tremendous success. And you can see with the school program on your left, red counties being counties that have had their training as well as their kits in place. You see we only have 4 counties that don't have kits yet, but they are undergoing their training. And then the school bus driver said, well, we're at high risk. We have incidents on our school buses. We need kits as well. So we turned the project around and spent another $500,000 on kits for school buses. And then the same process with training took place again. You can see we're not quite as far along there, but probably 75, 80% of the state school buses have their kits in place. Now, moving into financing, as the trauma room or trauma resuscitation room in the ER, as it is the main part of the trauma center, if you will, or at least the entry into the trauma center. This room, the well at the Senate in Georgia, is the trauma resuscitation room for finance. You see here at that time, Lieutenant Governor Casey Cagle, at Sandy Die, which is the when the clock strikes midnight and the last day of the session and the session ends, any bills or anything that's on the legislator's desk, they celebrate by throwing those up in the air, and it's a moment of celebration. We've seen a lot of great legislation. I remember one time standing there at midnight, watching a battle between the House and between the Senate on a bill that was worth about $100 million that never made it for a vote. So there's been some terrible failures, but then again, some incredible successes in this room. So with financing, we want to identify a dedicated and sustainable funding source for the essential administrative personnel and infrastructure costs, linking funding to deliverables to support performance improvement in the areas of system management, access to care, patient safety, outcomes, and financial stability of the system. This is the recommendation. So we're trying to follow the recommendations. We use this as our playbook. This was from ACS. We didn't think all this up. We weren't smart enough to do that, but with their guidance, they gave us the roadmap, and we attacked these bullet points one at a time. So with that being said, our revenue, we finally hit pay dirt. This was established in 2010. This was from Governor Perdue. At that time, it really didn't seem, there was some pushback, like, this is maybe not what we need to do, but it turned out to be really the foundation for what we do. And it was the super speeder law, or super speeder fine, which gives $200 fine for traveling greater than 75 miles per hour on a 2-lane road or greater than 85 miles per hour on any road. This is in addition to the average speeding fine. So this is a separate fine that goes just for trauma, and revenues are deposited into the general fund. Now, I said it goes just for trauma. That's a little bit of a misnomer. That's not true. As I started learning about state government, I realized that there's trust funds and then there's the general fund. And this was in the general fund. So you can see in blue, it's the super speeder revenues from 2011 all the way up to 2023, running at about between 21 and 23 million. You can see in red is the allocation to the Trauma Commission. So you can see there for several years from 13 to 18, we never were made whole. We would only get a portion, maybe about 16 million of the funds. And so some of you might recognize this as a dean's tax. You know, the legislators could use any other funds for other projects if they so desired. And we would have to go every year in January in the supplemental budget and beg for to be made whole. So fortunately, legislation passed in the last year or so to where we now are made whole and we have the Georgia Trust Fund. So all this funding has to go into the Trauma Commission budget. Our only secondary revenue source, this was established in 2016. It was the firework excise tax. You can see the year from 2017 to 22 listed in the table, the revenues generated in the middle, and then the allocation to the trauma on the far right. And if you go to look at 2022, you can see this tax revenue generated about 2.7 million, for which by law, by legislation, the Trauma Commission received about 1.5 million. Here's the bill that I was talking about that is so incredibly important, that helped us get over the hump of the general fund versus a trust fund. House Bill 511, appropriation of dedicated revenues. It said that whatever was appropriated for a particular trauma source, this had to go to trauma. And it established the Georgia Trauma Trust Fund. But you can see it only took 12 years. So again, take home message today, this is a marathon, not a sprint. So now looking into deliverables linked to performance. This was another key metric that ACS said we needed to do. So we started looking, how do we tie deliverables to performance? And so we came up with performance-based payments for trauma center readiness costs. Our trauma centers, at that time, Senate Bill 60, before it became code, stated that we had to give trauma centers funding in the form of readiness costs, in other words, to maintain readiness, and then in the form of uncompensated care. So we started developing metrics that that put money at risk. The trauma centers did not get all of their readiness costs unless they met certain metrics. This was totally new for the state, so we started very slowly. You can see in 2010, only 10% of readiness cost funds were set aside for performance-based payment program, with only 3 performance criteria. Very gentle. The commission didn't want to withhold funds from the trauma centers. We wanted them to get all their funds, but we did want to introduce the concept of performance being important, with the idea that once the trauma centers learn to do this, then we could increase the number of metrics. And you can see by 2019, with a gentle, slow approach, we were up to 80% of funds were in the payment performance-based program with 11 performance criteria. And you can see these are broken down, these criteria, into different domains, either system participation, ACS optimal resources, the orange book now, the gray book, or charcoal book, and GQIP enhancement, which is the Georgia Quality Improvement Program engagement. In other words, participating in quality. And you can see the breakdown is not the same for each level of trauma center. The level 1s and level 2 brunt most of the criteria or carry most of the weight at 80% of readiness costs at risk. Level 3s are at 60%, our level 4s at 19%, and then the burn centers at 50%. So now moving into evaluation and performance, sort of the last piece, if you will, that has all these other things had to take place, really a 10-year mission to get to this point, and we are just starting to stick our toe in the water with this, but it's a huge step forward, but again, tremendous work and effort to get to this point. And that's to develop and implement statewide and regional trauma system performance improvement plans. This is right from the ACS. Again, another recommendation, but boy, it was one of the hardest ones. It's taken us a long time to get there. So when we started looking at this, TQIP, trauma centers are members of TQIP. That's a great trauma quality improvement program. Many trauma centers are also, or most are also, members of NSQIP, or the surgery quality improvement program. So we said, if the commission is going to fund quality, why not there's so much overlap. Why not pull these two groups together? Have a champion for TQIP, a state champion, have a state champion for NISQIP, and develop collaboratives in each with reporting. And we came up with the Georgia Surgical Quality Improvement Program. To my knowledge, this has not been done before. This was sort of cutting edge at the time, trying to pull these two together and conserve resources and not spend money on two different collaboratives independently. Let them work together, because it's usually mostly the same people at the same place. And we working with ACS, which TQIP was incredible. We really didn't have state collaboratives back then, as far as and we told them we would like all the trauma centers put together into one box, if you will, and be called the Georgia Trauma Center. And so they were very kind and very adaptive to work with us. I can't say enough about the staff at ACS TQIP that helped us develop our collaborative report, our report card, if you will. But be careful what you ask for. As you can see here, our 2016 risk-adjusted major complications report for the state, again, all the level 1 and level 2 trauma centers together into one trauma center, and then compared to the rest of the nation, we had a lot of red. And as our executive director, Liz Atkins, says, you don't have to be a statistician with high-level statistics to know that red is bad. Really, all the metrics, we were in the red except for one, and that was isolated hip fracture. So we knew that we had some work to do, but it told us that we had problems and we needed to get started. So with that, we knew that ACS consultative visits, as well as verification status, led to improvements in outcomes. That's been documented in the literature. Fortunately, in 2015, our first verified trauma center in Georgia through the ACS, or at least recently, was the level 2 trauma center. I believe Savannah, many years ago, back under Gage Oshner, was probably the first. I want to give them credit for that, as far as being ACS verified, but then that was not sustained. But in the recent era, you can see it was in 2015. ACS consultative visit was required for level 1s and level 2s by the Trauma Commission in 2017, as we wanted to start moving quality forward, and we knew the consultative and verification process would. This was a huge undertaking and a big step and a big shock for our trauma centers. So we started gently, giving them plenty of time, 1 to 2 or 2.5 years to just get a consultative visit going, not to correct everything, but just to get a visit. I think it was over a year just if you turned in an application. So we were very gentle in the process. Eventually, through the consultative process, we learned a lot. Centers went to work. And then in 2019, we realized we needed to set a date for verification. So you can see there, June 30th, 2023, we mandated that for centers to get funding, to be funded through the trauma process, they have to be ACS verified by 23. And this has progressed on, that you can see in 2021, 8 ACS verified trauma centers, and then 2022, 12 of the 32 trauma centers are ACS verified. And of course, a lot of those are several of those are level 4s. So did it work? Did consultation and verification, putting us under the microscope, did it work? Well, I think it did. You can see here in our GQIP report in spring, our collaborative 2021, which is risk adjusted from TQIP, you can see all our diamonds are black. All patients, blunt multi-system trauma, penetrating shock, severe TBI, elderly, and so on. So again, eye-opening, a moment of shock at first, but I appreciate everyone's hard work. This has been a state effort to move these diamonds from red to black. So then what about next steps? As you know, TQIP is only a biannual. Every 6 months we get a report. It takes a long time to implement state projects and to see if it has an improvement on outcome and quality of your trauma centers. So we've decided to replicate the Michigan model, or MTQIP, if you will. As you know, they're really I would consider the leaders as far as how to do this, with their, diving even deeper and getting more sophisticated than even TQIP, with real-time data, real-time analytics, evaluation. They implement a project, they can follow it for 3 months. They can see if it's working or if it's starting to bend the needle, if you will. And that's where we want to go. Also, we want to include our level 4 centers. Our level 3 and level 4 centers and our rural committee have just done tremendous work with tremendous enthusiasm, and they're so excited to be at the table. And we want to provide data for them so that they can continue to improve. So ongoing challenges as I finish up here. More funding is needed to expand the system. Again, if you want a number, I can give you a number, and I've got the data to back it up. It's old data. It's probably more now, but certainly somewhere in the $80 to $100 million range so that's, again, that data is several years old. But if you combine in readiness cost, if you combine in uncompensated care, if you bring in EMS, which was woefully underfunded, and we have tremendous needs, and it's somewhere in that $80 to $100 million range, and we're at 23. We need recruitment and retention of trauma centers, particularly in rural areas, as Brian pointed out so nicely on his map. And then level 4 centers, validating the quality of care in level 4s and underscoring the vital role they play in the trauma system. We're not going to be able to have a level 1 trauma center in every area in South Georgia. So the rural hospitals stepping up to the plate and being level 4 centers, stabilizing patients, being a strong component and part of a network, and getting those patients transferred in a timely fashion, again, which brings EMS into it, which was tremendously stretched at this point, trying to cover stroke, trying to cover STEMI, trying to cover trauma in these rural areas. They have to be a part of the puzzle, which I'm sure will come out in this week's discussion as well. So with that being said, I'll stop there. And again, I thank all the partners. This is not one person. This is not one group of people. It's not one stakeholder group, and certainly not one agency or hospital. It's a team effort to get to where we are. So I will stop there, and Liz, turn it back over to you or Brian, whoever is going to take questions or continue. Thank you.
You got it, Dr. Eastridge?
No, I just in closing this morning, again, we are when Dr. Ashley gave that talk at at our COT meeting, it really was probably one of the most profound, eye-opening events in our meeting that we've had in several years. We've had so much interest in Dennis's talk because of all of the work that's been done in the state of Georgia and all the success that the state of Georgia has have, and people really want to emulate what's going on in Georgia. We are really looking forward to our visit next week, and looking forward to meeting all of you that are online as participants. I will say one thing in closing. What makes this a success, and what makes this a success for you as stakeholders, is participation. So I would just ask that just maximal participation from the group will really, I think, yield benefit for the state of Georgia.
Thanks, Dr. Eastridge. And we're going to post the recording of this for folks who couldn't attend on our website. And thanks to to the team, Mackenzie and Holly. I've got your presentation. We'll put those up as well. So thanks, and we'll look forward to seeing you.
Great. We look forward to seeing you next week.